CRNAs. A lot of this is going to be more on the basic side, but that's okay. When you're talking to a group that comes from so many different levels, people that haven't started CRNA school all the way to practicing CRNA, there's so many different, levels that you could take this at. And so I'm kind of going to go kind of right in the middle. So start with some basics. So if you're in the ICU, this might be a little bit more than what you know. And then if you're a senior, this might be a little bit of a easy refresher for you. The purpose of this introductory session is that, I want to introduce you to a bunch of different topics. And then if there are topics that you're like, let's take a deeper dive in this specific drug class or these specific topics, I want you guys to let me know. And then in future webinars, we could just focus on, one specific thing. Because I'll be honest with you, every single one of these slides can be an entire lecture on its own. So let's get started. All right. Introduction to Anesthesia Pharmacology. Who in the chat has never taken a graduate level pharmacology course? If you've never taken one, like either raise your hand or say in the chat that this is like your very first time being exposed to more like graduate level pharm. Okay, there's a couple. Valerie, Haley, Elliot. Nice, Lauren. Okay, cool. So this would be great for maybe even a little bit overwhelming. Course in progress, nice. A little bit overwhelming because a lot of it is going to be brand new to you, and that's okay. Just let it kind of wash over you. Is what I tell people. If you're hearing some of this information for the first time, and we could certainly go into a couple more topics. And then I'm assuming that the rest of you are either in CRNA school or are already practicing. So cool. So every time I start a webinar, I know there's a lot of people that have been here before, but for those of you that are new, I want to tell you just a little bit about atomic anesthesia. So Sachi and I came together about 18 months ago. I can't believe it's been that long now. And we both kind of on our own were on this journey to provide nurse anesthesia residents with more high quality learning, educational material and information for people that are going through their anesthesia journey. We try to be a little bit more creative and innovative with the way that we deliver that information. We want to focus on, micro learning and gamification, which now are big buzzwords, but I felt like even just 18 months ago, that was such a foreign concept to a lot of professors. We want to build community, which is why we do these webinars. And we also really want to focus on academic integrity and making sure that the information that we're giving you is the highest quality, most accurate information possible. So our mission ultimately is to support you through your CRNA school journey. Now, an outline for today. Like I said, with this topic, I could honestly talk about pharmacology for, 50 hours straight. So how do you compact this entire field into, 45 minutes? And so I've decided that what we're going to do is do, a brief overview and introduction and talk just very briefly about some PharmD and PharmK principles. And then we're going to focus the bulk of this lecture on some neuropharmacology principles. And the last part I threw in there last minute, but I think this is going to be really fun. We're going to do a top drawer drugs kind of session where I don't know if any of you have ever heard of this before, like being quizzed on top drawer drugs. Yeah, I'm seeing some people nod their heads. So it's literally when you're in the operating room and the CRNA starts opening drawers of drugs and just pointing to them and being like, what's this? What does this do? What's the dose? Blah, 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 blah. Next one. It's kind of this like rapid fire round. It's really intimidating because within like these three drawers, there's probably 100 drugs, and they could just pick any of them at any time. So when I was at my clinical site the other day, I took my iPhone and just kind of like took videos of these drawers and I listed all of them out on these slides. And that's what we're going to do together. We're just going to do this like top drawer drugs kind of like rapid fire round. And I think that'll get you ready for the types of drugs that you might be asked questions on. And I'll give you a couple. Well, we're actually going to use the chat a lot. We're going to go back and forth and everyone's just going to share everything that they know about those drugs. I think it'll be a fun session. If you want a copy of these slides, slides, now's your chance. Take your iPhone and use this QR code to download the slides. You should have access to it there. So I'll give you 20 seconds to do that. Yeah, first year preclinical, and that sounds great. Well, I got the idea because somebody on Instagram told me that they had their top drawer drug quiz next week. And I'm like, oh, now we're quizzing them. We're quizzing people in class for that. Is anybody else having that? You're getting like quiz. Yeah, Dorcas is like, yeah, you're getting. I mean, I only got grilled in clinical for it, but I guess now they're doing that as in class exams. So yeah, it's brutal. So hopefully we'll get through that. All right. I hope that everybody had a chance to download the slides. And if you didn't, let's see if I still have there we go. I put it in the chat there. This the link also. Same one. Cool. Let's get into it. So, resources. These are my top books for learning pharmacology. The Stolting you might want to screenshot this, or this is in your slides as well, but the Stolting is the one that is assigned to every CRNA program. Stolting's Pharmacology and Physiology and Anesthetic Practice. It's the main one that's on the CNCE bibliography. It's what a lot of the board exam questions are written about. So this is probably your primary book. There's also some pharmacology knowledge in Nagelhout as well, but this is the main pharm book used in CRNA schools. Um, the Now most of you know that I'm getting my PhD in pharmacology, which I'm finishing up actually in just a couple weeks. So these are the other types of books that as a pharmacologist we use to learn pharmacology. So I think the best one is Kat Zong's, this one here. Basic and Clinical Pharmacology. It's like this on steroids, but really well written and not too dense. I think that even somebody that is not a pharmacologist would get a lot from this book. So these are my top two favorite. Um, Rang and Dale's is another one. It's a little bit more dense. Goodman and Gilman's is like the Guyton's version of pharmacology. Super dense, but it's got all the nitty-gritty detail if you want to just step it up a little bit further. I don't recommend that you start here. I think that you should start in these two books, but if you're just looking for something like on steroids, this is your book here. So that's Goodman and Gilman's. The last book I also recommend is Guyton because, and I'll get into this in a little bit, is that in order to understand pharmacology well, you would need to understand physiology well. You really can't understand pharmacology unless you understand physiology. So getting that good physiology and pathophysiology foundation is crucial for understanding this field. So I love asking this at the beginning of every session. So what stage are you in your career? I could launch a poll, or you guys can just say you just say in the chat. Haven't started school, junior, senior, or you're practicing. So most people are like A or B applied. Oh, my friend Becky's there, the 1D that's in there. Thanks for coming, Becky. She's a practicing pediatric cardiac CRNA in Texas, which is pretty cool. You don't meet too many of them. Graduate in May. What? Cool. So mostly haven't started or juniors, some seniors and Becky. Nice. All right. So I love asking this question as well. And I teach pharmacology at Drexel, and I ask this at the beginning of every lecture. How do you feel about pharmacology? Is anyone out there like love it, hate it, scared of it, makes you anxious? Like, what is your general hate it was the first one. Necessary evil. Yep. Challenging, love-hate relationship. Love it. Love hate. Yeah, I definitely get that. Challenging but interesting. I know when I was an undergrad, I really didn't care for it. And then when you become a CRNA, you realize like you are a pharmacologist, essentially. You know, you can't do your job without being a pharmacologist. So I learned to embrace it. And then when I was going for my PhD, I thought, well, this is really the best fit for me is to really dive into it and lean into it. It is overwhelming for sure. And we're going to get into why that is and why it's so challenging for people. And of the pharmacology topics, what do you think is just the most confusing, the most challenging, just kind of like your kryptonite? pKa. Inhalation, antibiotics. Oof, I think antibiotics might be my kryptonite too. Inhalational agents has been the hardest. Uh-huh. ANS, immune drugs, pain pathways, pKa, mental health meds, regional. The patho that leads to mechanism of action. Opioid receptors, PK, a lot of pKa. PKA, we're not going to get into that for this lecture. I mean, it's an entire lecture on its own. Maybe we should have a webinar about that. But for those of you who aren't familiar, PKA has a lot to do with local anesthetics. That's usually when we talk about it. Nice. All right, let's get into it. So, what is pharmacology? Right. It is the study of substances that interact with living systems through chemistry, basically. And it's so interesting because I think sometimes we think in our heads that the way that pharmacology works, it's almost like drugs have like their little brains and they think about what they're doing and where they're going. And there's this kind of more intelligent system when what it really comes down to is chemistry. They're random chemical interactions and the body's physiology and the chemical structure of the drug determines what happens to the drug and what happens to the body based on just random interactions. So keep that in mind. It's not like the drugs have brains and they know where to go. They go where they go because of chemistry. And I think that's sometimes what makes pharmacology super challenging if you don't have at least a decent foundation in chemistry. And that itself is the kryptonite of so many people, right? Biochemistry, organic chemistry, it all comes back, or mathematics, when you're learning calculus and algebra. We'll get into that in a little bit. So it's all these chemical processes, studying these substances that interact with these living systems. And this occurs because these substances, these chemicals, they bind to different targets in your body and they either activate it or they inhibit it. And simply, of course, there's lots of exceptions to everything. Everything that I say is going to have an exception. But overall, the general gist is that chemical binds to target, which either turns something on or turns something off. That's the essential basis of pharmacology. And we get into a little bit more nitty-gritty, medical or clinical pharmacology is essentially what we're studying, which is when we use it to either prevent, diagnose, or treat disease. I think sometimes people get the terms mixed up a little bit, pharmacology versus pharmaceutics versus pharmacy. And the main difference between these terms is that pharmacology is the study of drugs, pharmaceutics is the manufacturing of drugs, and pharmacy is the dispensing of drugs. Oftentimes, when I tell people I'm getting my PhD in pharmacology, and they're like, "Oh, so you're a pharmacist, right?" I'm like, "No, I don't dispense drugs. I design drugs. I study drugs." So a little bit of a difference, but just a little nomenclature there. Like I said, what makes pharmacology so difficult? And it's because it requires the knowledge of so many other disciplines in order to understand it, right? You need to have a very in-depth understanding of just how the body works, right? During normal processes and during abnormal processes. If you want to understand how anesthesia pharmacology works, you need to know how the central nervous system works. That's, what it comes down to. You need to know how neurons work. You need to know how action potentials work. And until you understand that basis, you won't understand pharmacology. And it comes the same, down to disease as well. How the body works when it is diseased or not functioning properly. It's difficult to understand how an antidysrhythmic works if you don't understand how arrhythmias work, right? So this is just totally essential. And I tell residents all the time and people that are learning, if you understand physiology, you can solve any problem, period. If you understand how the body works at the molecular level, everything comes way easier to you. If you break that down a little bit more, we're looking at, cellular and molecular biology. I'm not talking about identifying organelles in the cell like sixth grade biology. Now we're talking about very, very molecular level biochemistry, when you look at the phospholipid in the cell membrane, what is the chemical structure of that phospholipid and how does that interact with the chemical structure of the drug you just gave? Or the receptors that are within the cell membrane are made of proteins. Proteins are made of amino acids. Amino acids, what does that come down to? Nitrogen and carbonyl groups, and how does that interact with the chemicals that you just injected into the body, and how does that change the physiology of the cell? What's happening outside the cell, what's happening inside the cell? It's really does come down to that like deep molecular understanding. Understanding all different types of field of chemistry, understanding your functional groups, learning your ethers again, esters, amides, seeing how those interactions interact with the same types of functional groups that are within your body. And then bringing back the math. I'm teaching people about dose response curves. A lot of times these are in logarithms and trying to explain again to people what logarithms are. So it's like you can't understand one thing until you get your foundation. And I truly think this is why pharmacology can be challenging. But if you understand that maybe you have a deficit in one of these things, then you get closer to being like, okay, well, my learning curve is going to be steep, but if I kind of build my foundation, then the pharmacology is going to get a lot easier for me. Does that make sense? How it's just kind of this culmination of so many different fields. Pharmacology in itself is a massive field, right? We're learning clinical pharmacology, but you could see that there's just so many other fields. And even as a pharmacologist, I work with people from all these different um, fields. Genomics, pharmacogenetics is exploding right now. There's lots of CRNAs that are actually getting their PhD in that. I'm sure a lot of you know Edwin Aroki. He's one of the famous PhD CRNAs that has his PhD in pharmacogenomics. So that's kind of an up and coming field as well. So, what are the three pillars of pharmacology? Most of you have heard these things before. We've even talked about this in undergrad nursing school. Pharmacodynamics, pharmacokinetics, and then the third one that you're going to learn a lot more in grad school is pharmacogenomics or genetics. We know that pharmacodynamics is basically how the drugs affect the body. So, what the drug is doing to the body, how it's interacting with its targets, the things that it's changing within the body. The pharmacokinetics is, we talk about it about what the body does to the drug, but it's a little bit more than that. It's how the drug kind of gets into the body, moves through the body, and leaves the body. So it's kind of this dynamic interaction between both, right? The body is eventually taking that drug and breaking it down and getting rid of it. Pharmacogenomics is an interesting new field and looking at how somebody's genetics really impacts the medication response. Why is it that when I give somebody anesthesia, person A and person B, who seemingly look the same, maybe have the same ethnicity, the same age, the same sex, the same everything, everything looks the same. But one person wakes up right away, and another person B takes an hour to wake up, an hour to recover, and they got the same drug. And that comes down to the pharmacogenomics and makeup of that person. Maybe person A has different metabolic enzymes than person B. We can't see that on the outside, but internally, a lot of these changes do affect the drug response. So that's the entire field of pharmacogenomics. What's interesting, just a side note about pharmacogenomics as well, is that we're trying to use the knowledge that we have from pharmacogenomics to then predict the patient's response. You can imagine how challenging that probably is and how costly that might be. But it is an up and coming field. And if you're definitely interested in, exploring a DNP project in that field, I think it's a great idea. And you'll have some mentors out there for that. If you have any questions, just throw them in the chat and I will, or you can just unmute yourself and blurt it out. I'm used to that during my teachings, during my classes. Let's briefly talk about the types of principles that you might see in these, basic pharmacology fields here. So pharmacodynamics, what the drug does to the body. This is looking at a lot of the chemical cellular interactions of drugs and really looking at their mechanisms of action. One of my favorite things to talk about. There's a lot of math involved in pharmacodynamics. We talked about dose response curves. We will talk a little bit about drug targets. So when you're learning about pharmacodynamics, big part of it is learning certain drug targets like G protein coupled receptors, ion channels, tyrosine kinase receptors, all these different targets that drugs can potentially bind to or work on. We'll talk about drug targets in a little bit more detail. The chemistry is a big part of pharmacodynamics, so the size, shape, and bond of those chemical interactions. Big part of this field is, I'm sure some of you have heard of enantiomers. Have some of you heard of that? Enantiomers, chirality. So if you are not familiar with that, drugs often are made in what we call racemic mixtures. Racemic mixtures are when you have a 50% mixture of drug A and then a 50% mixture of its mirror image. We can call that drug B. They look identical, but they're not the same compound. And the reason why that happens is during the manufacturing process, it's not the most pure process. I guess that's the easiest way to say it. When you have chemical interactions and chemical bonds that occur, they don't always occur in the same exact way. So you have this 50-50 mixture of like your pure substance and like your impure substance. Um, the where this comes into play is that sometimes that impure mirror image, that B, drug B, is responsible for these off-target side effects and adverse effects that you might see. So that's a big part of understanding pharmacodynamics. There's certain medications that, for example, like ketamine is one that we talk about a lot, that has a racemic mixture that has adverse effects. You've heard of the term agonist, antagonist. Gets a little bit deeper than that. We go to the partial agonists. We get into drugs that are agonists and antagonists. There's various different types of antagonists like orthosteric, allosteric antagonists and whatnot. Reversible, non-reversible. So there's lots of different categories under that as well. Pharmacokinetics now looks at how the drug moves through the body, so absorption, distribution, and then what the body then does to that drug to get rid of it. Metabolism and elimination. We always think of pharmacokinetics basically in these four categories. So ADME, absorption, distribution, metabolism, and elimination. Just think your body is just constantly inundated with toxic chemicals all day long. What you eat, the things you rub on your skin, the things that you breathe. Your body has evolutionarily, evolved to just deal with all this junk all the time. And so you've built up this whole arsenal of metabolic enzymes, not just in your liver, but in nearly every kidney and cell in your body. You have these enzymes in your kidneys, in your lungs, in your blood cells, and just floating around in your bloodstream to constantly deal with the chemicals that get into our body. And so it's a big part of pharmacology also is just understanding where these enzymes live, how they work, and how they interact with the drugs that you're giving to people. So, when we think about drug, I want to focus a little bit on drug targets. Like I said, when I teach pharmacology, like pharmacodynamics and kinetics and genetics, they're all separate 3-hour lectures, and we're still skimming the surface of the topic, right? There's a lot to cover. So I just want to focus on drug targets because I think that's probably the most high yield for this lecture. So, where did this all start? There is this gentleman in the mid 1800s, early 1900s named Paul Ehrlich. He discovered a drug to treat syphilis, which he called the magic bullet. And at this time, before then, people really had no idea how drugs worked. They know that they gave, compounds or tinctures or whatever, and people either got better or got worse. It really was like a crapshoot back then, right? Um, they don't really know how things work, and this guy has this theory when he's making this syphilis drug that a drug will not work unless it's bound to something. And he had these really, really rudimentary drawings of what he thought was kind of happening in the body. And it's actually kind of cool how accurate it really was. So he pictured the cell and he figured there was something on the cell that his drug, this magic bullet drug, was had to bind to in order to have its effect, in order to have like cellular effect. And he was the very first person to come up with this theory. And so he really is kind of the father of this receptor theory. Um, and and really, the models that he created, the pharmacological receptor models, really predated by many years before we could scientifically demonstrate that this was correct. He actually did end up winning a Nobel Prize for his discovery. So the receptor theory kind of started with this gentleman here. When we look and understand drug targets now, there are many. Perhaps the one that is the most common, that has the most amount of drugs created for in market, is the G protein coupled receptor. These are your adrenergic receptors, they're your muscarinic receptors, so your alpha, your beta, and then your muscarinic receptors, which is a type of cholinergic receptor. So most of your cardiac drugs work on G protein coupled receptors. There a lot of times with G protein coupled receptors and other types of receptors, what's happening is a drug or a ligand like epinephrine is binding to the outside, and then it causes a change to occur, which is called like a conformational change. So it kind of twists this protein and activates something on the inside. Something binds on the outside, activates something with the inside. Nothing passes through the membrane. And what happens here is this then turns on a whole signaling cascade within the cell. I'm not going to go through the G protein signaling cascade because it's quite lengthy. But just to give you an idea, this is probably the one that there are most marketable drugs for right now, is G protein coupled receptors. Also, lots of drugs, anesthesia drugs that we give are working on ion channels. We're going to talk about the GABA receptor in a little bit, but most of our anesthetics are going to work on the GABA receptor, which is a type of ion channel. You have sodium channels, calcium channels, potassium channels. GABA is a chloride channel. And then you have other channels like NMDA, which is a glutamate receptor. They allow ions in or out of the cell. And then we have drugs that either block these channels or open these channels to have its effect. These are probably the ones that you've heard of the most often. We call these metabotropic, we call these ionotropic. But then we have a couple more targets here that you have given the drug before you, but you might not have known how the drug actually works. One of the other types of drug targets that are out there are called TKRs or RTKs. They're tyrosine kinase receptors. Essentially, what's happening here is that you have two proteins that exist in the cell and don't touch each other. They exist as monomers. And then when the drug binds, it brings these two together to form a dimer or dimerization. And these, when they touch each other, they kind of activate each other. So you could think of like, you know, two people that are single, and then you have like a matchmaker that brings them together, and they kind of like, jive well and turn each other on, I guess, whatever. This process is called autophosphorylation, and same thing. It will bind to the outside and turn on a whole series of signaling cascades within the cell. One of the drugs that works with this mechanism is insulin. So one of the end results of this signaling cascade that occurs is it takes a glucose transporter that is sitting and floating within the cytosol and inserts it into the cell membrane. And by doing so, it allows glucose to then enter the cell. Okay. But you can see there's a lot of steps that occur for that to happen. So these are tyrosine kinase receptors. Other types of receptors, now these ones are bound on the cell membrane, these first three. But there are other receptors that just float around in the cytosol. They don't touch anything. And one of these types of receptors are called nuclear receptors. So they sit outside the nucleus, but they're not bound to any membrane or anything. And what the drug has to do in order to turn it on is it has to pass through the cell membrane to get to the receptor here. turn it on, and then that receptor goes into the nucleus and actually um, turns on, activates a piece of DNA or inhibits a section of DNA, which either turns on or turns off um, protein translation as the end result. So new proteins are being made or prevented from being made. One of the examples of medications that does this are steroids. So if you give dexamethasone, if you give hydrocortisone, methylprednisolone, any of these drugs, they're very lipid soluble because they have a cholesterol backbone. And so they can just very easily just pass through that phospholipid membrane, activate that receptor, and then it's going to either increase or decrease translation. So we have dexamethasone there. These are nuclear receptors. Another drug target would be enzymes. We've given ACE inhibitors. We've given statins. Statins block this enzyme called HMG-CoA reductase. This is an enzyme that's involved in making more cholesterol. So if we block that, we can decrease cholesterol levels. Normally, enzymes have a binding pocket in which the substrate will go in and then break up into products. The drug will go in, block that substrate pocket, that binding pocket, so that substrate can't go in and have its, enzymatic effect. So that's how enzymes work as a drug target. When it comes to, well, what drugs do we need to know to be a CRNA? There are a lot. This is from the CNCE outline. These are the drugs that are tested on the board exam. There are approximately 30 to 40 drug classes that are tested. So within each drug class, you could see there's like probably at least 10 to 20 different drugs that are within each class here. So a lot of these are working in the nervous system, so inhalational anesthetics, IV anesthetics, muscle relaxants, local anesthetics, different types of adjuncts, opioids, a whole list of cardiovascular medications. So a lot of these medications on the left, I would say we administer. A lot of the medications on the right, not all of them, but a lot of them, these are maybe medications that patients take, and we worry about drug interactions with our medications. Not all of them, but some people come in having taken their antiplatelet medication. How does that interact with the medications that we give? People are on antidepressants, antipsychotics, they're on herbal medications. They have Alzheimer's and they're taking their, or their Alzheimer's medication, the anti-Parkinsonian medication. All of these drugs that interact with their cardiovascular system or their nervous system interact with our drugs or vice versa. So having just a good understanding of all these different drug classes are really what it takes to practice as a competent CRNA. It's a lot. Here are my quick tips for how to approach pharmacology. I'm going to harp on this again. I said it before. Build your foundational knowledge. When you understand physiology, you can solve any problem. And if you take a step back and really, if you don't understand something, it's probably because maybe there's just a piece of like chemistry information that you don't quite understand. There's some molecular biology information that you don't quite understand, because once you get those foundations, then the pharmacology comes a lot easier. A lot of you know this, but I'll reiterate again. Try to learn the drug class, not the individual drug. If you learn the drug class really well, a lot of those um, things that you need to know about those classes apply to most of those drugs. Once you understand the drug class well, then you can look at the individual drugs and try to see what's different between them. For example, let's say beta blockers, right? You learn everything you need to about beta blockers. Once you understand the drug class really well, then you're like, okay, what's the difference between metoprolol and labetalol? Or what's the difference between that and propranolol? Or what's the difference between that and esmolol? And so now you can get into a little bit of more of the minutia and say, okay, well, labetalol works on both alpha and beta receptors, whereas metoprolol works on just beta receptors. All right. Esmolol has a much different duration of action than metoprolol. So you start kind of getting into like what's different between these drugs. But first, learn about the class in general, because most of the things you need to know about the class applies to just about every drug within that class. Mind mapping. If you don't know what mind mapping is, there's definitely lots of YouTube videos out there that explain how to do this. Here's an example here of mind mapping antibiotics. It does work really well for learning pharmacology. I definitely recommend it. So I'll take you through this antibiotic mind map here. When you look at the class of antibiotics, we start to learn that the way that antibiotics work are through several different mechanisms. It can either, and you have to learn a little bit about the biology of bacteria and viruses. You can give drugs that break down the cell wall, the cell membrane, the DNA, the RNA, or basically protein synthesis. So it's just messing up the mechanics of the bacteria or the virus. And so we're like, okay, I'm going to mind map that and I'm going to break the drugs up into these like five or six different sections. So let's just take cell wall synthesis because everybody knows penicillins. So from there, we have the beta lactams. And then from there, we could break it up a little bit more into the cephalosporins and the penicillins. And so mind mapping is basically just breaking each thing down into like smaller and smaller groups. And so when you take your exam and you have your mind map, and you can't use somebody else's mind map, it doesn't work that way. You have to use your own mind map because the part of the mind map is like visualizing where you put things. You're like, okay, I remember on my whiteboard, my massive whiteboard, I put this thing over up in the right-hand corner, and I drew out beta lactams and everything. And it's a good way for you to sort out all these different categories within this entire drug class, which is antibiotics. Did that make sense about mind mapping? I think I used mind mapping a lot when I was learning different drugs. There's so many cool tools out there that you could use now. A lot of residents that I teach, they just do it on their iPad and they can kind of like zoom in and out of it and make these really crazy mind maps. But I think it works quite well for pharmacology if you're into that kind of thing. I'm gonna pause and see if you guys have any questions so far before we get into some molecular details. Any questions? All right. We'll keep pushing forward. We're gonna get into a little bit of like a little bit deeper into the biology. I think for the seniors, this is still quite a review for you. For people that are just starting out, this might be a little dense for you. And maybe for the juniors, this will be a good fit. So let's get into it. Neuropharmacology. What are the top medications that we're going to use as CRNAs that relate to neuropharmacology? They are our general anesthetics, our pain medications, and our muscle relaxants. So the main drug classes are your inhaled anesthetics, your IV anesthetics, and this includes, sedative hypnotics that create full general anesthesia, and then your ones that give you more lighter sedation, like your benzodiazepines. And we have our analgesics, which includes opioids and non-opioids. We have our local anesthetics, and then we have our neuromuscular blocking drugs. These are the main medications that we need to know to practice anesthesia. There are a lot of other medications that are within the field of neuropharmacology. We don't give these medications, but a lot of times our patients come in being on these medications. So you can imagine they're on a medication that modifies the central nervous system. We're giving a medication that also modifies the central nervous system. There are only so many targets in the central nervous system, right? So if they're taking something and we're giving something, we're bound to have some kind of drug interaction. So we have to still understand how antipsychotics work, how antidepressants work. There's a lot of people out there that have substance use disorder or just take party drugs on the weekends and they come in after having been in a car accident and they are acutely intoxicated with polysubstances, right? They could be on alcohol and on stimulants or hallucinogens or whatnot. So really understanding how all those interactions occur. We're going to break down neuropharmacology into, I would say, the various physiological areas. So I'm not going to talk so much about drug class. I'm going to talk more about the physiology of the CNS and talk about the couple of drugs that kind of interact within this area. That's I think the most efficient way for me to give this lecture within, an hour. So we'll talk about first synaptic transmission. I think a really important part of learning anesthesia pharmacology is really understanding the nerve to nerve synapse and the nerve to muscle synapse and looking at the real, molecular details of what's going on within these like nerve to nerve junctions. So you have your axon that then's going to your dendrite, learning about what's happening with the action potential, how that action potential then stimulates these ion channels at these end bulbs here to stimulate these vesicles that are holding neurotransmitters to then bind and fuse with the cell membrane at the end here, which then releases neurotransmitter that travels across the synapse and stimulates some kind of postsynaptic receptor. Okay. And that receptor could be a whole host of receptors that are within the CNS. But the ones that we focus on the most in anesthesia pharmacology are really two receptors. One's the GABA receptor, and one is the NMDA receptor. These are some of the main receptors, and then the rest are ion channels. Well, these are ion channels as well, but I mean, sodium chloride channels and calcium channels. So let's talk about the GABA receptor. The GABA receptor is the one receptor that most of our general anesthetics work on. So it is an ion channel. It's actually a chloride channel, and chloride is a negatively charged ion. When drugs like propofol or etomidate or even our inhaled anesthetics, benzodiazepines, bind to the GABA receptor, what happens is it opens that channel and chloride ions flow through into the cell. And what happens is when you have a negatively charged ion that goes into the cell, it makes the inside of the cell more negative. And when a cell becomes more negative, it hyperpolarizes or gets further away from that depolarization threshold. And so it's actually going to just start to shut the cell down a little bit, kind of like turn it off, be inhibitory. And that's what's going to cause that sedation to occur or cause that general anesthesia to occur because you're keeping the neurons from firing action potentials. So within the GABA receptor, there are the binding sites where GABA, this gets confusing because GABA is a neurotransmitter, and then you have the GABA receptor, which is the protein, right? So GABA, the neurotransmitter, binds to the GABA binding sites in the orthosteric pocket. The orthosteric pocket is like where it's supposed to bind, the endogenous ligand. But then you have a bunch of other little binding pockets that are not the GABA binding pocket elsewhere, and these are called allosteric binding sites. And allosteric binding sites are what these drugs bind to. So you have a site for propofol, you have a site for benzodiazepines, you have a site for barbiturates, you have a site for alcohol, right? These are all different sites. We tend to design drugs based off of their allosteric site because you can make it a lot more specific for just that receptor, right? GABA maybe is not a great example, but other types of neurotransmitters might bind to various different types of receptors, right? But say we only want to design a drug for the GABA receptor and not a different type of receptor, we might design it for one of these other binding pockets instead. For years and years and years, we did not know how inhaled anesthetics worked. Like we had some, lipid theory models and whatnot. Within, I would say, the past 5 to 10 years, we're starting to get a better understanding of how inhaled anesthetics work. And there's two main areas where we think that they're working. GABA being one of them. The problem with this GABA theory is that we can't find the binding pocket for it. We're not, so we know that it's working on GABA, but we just can't exactly figure out where it's binding to because sevoflurane, isoflurane, desflurane are very lipid soluble drugs, and the protein is, I would say, more of a water loving element, has a lot of charged elements to it. So we haven't really figured that out yet. The other target that we've seen is these potassium channels. And the way that it's binding to the potassium channel is indirectly. So it actually binds in the cell membrane very close to it. So it binds in the inside of the lipid membrane here. And then that turns on a chain of events that kind of takes these phospholipids, turns them into different molecules, which then activates the potassium channel. And the potassium channel works in an opposite way. So while chloride ions go into the cell and hyperpolarize it, when the potassium channel opens, the potassium actually leaves the cell, and it's the loss of the positive ions that actually cause the hyperpolarization as well. So either adding negative or losing positive is going to give you the same end result, which is an inhibitory result, right? It's going to turn off that cell. Ketamine is one of those anesthetics that we give that does not work on GABA receptors. They actually work on a different receptor, which is called an NMDA receptor. I think it's N-methyl D aspartate is what that stands for. But anyway, it's a glutamate receptor. Glutamate receptors are typically on excitatory cells, whereas GABA receptors are on inhibitory cells. So with the ketamine, it's actually going to block this receptor. So while all of these things here will stimulate the GABA receptor, the ketamine will actually block the NMDA receptor. And by doing so, you prevent the ions from going into the cell and activating it. So that's a brief overview of like synaptic transmission and what's going on with the anesthetics. Now we get into, and you could stop me at any time because I realize this is pretty dense stuff, but then we get into our opioids. How do our opioids work and how do our non-opioids work? With the non-opioids, it's a little more, there's a lot more mechanisms there, so we'll just focus on the opioids. I try not to say the word narcotics because that's not actually accurate in pharmacology. You'll hear a lot of clinicians say that a lot, narcotics, narcotics. Narcotics is a DEA term to describe a whole host of medications besides opioids. It's also used to describe cocaine, hallucinogens, stimulants, depressants, whatnot. They're typically substances that are illegal. It's more of like a legality thing. If you want to be precise, you have to use the word opioids. These are opioids, not narcotics. Okay. That's just the hill I'm going to die on. Okay. A lot of my colleagues will continue to use the wrong term. Okay. So when you want to understand opioids, you have to understand the pain pathway. And the pain pathway in itself is very complex. You have four main steps here where you take a stimulus that is going to stimulate the nociceptor, which is going to travel down the neuron to the spinal cord. Then it's going to travel up to the brain where you perceive pain. And your brain will then automatically send signals back down to the spinal cord to shut some of those signals off, or at least depress them a little bit, decrease them a little bit, so you're not getting overstimulated. The term you might have heard for this is the gate control theory. There's a lot of molecular events that are happening in the spinal cord right here. We're going to zoom in on this area here because this is where some of the areas where the opioids work. The opioids do work in the brain as well, but we're going to focus a little bit on what's happening down here at the spinal cord. So transduction is sending that signal. Transmission is going up to the brain. Perception is when you're kind of perceiving pain, and then modulation is when you're kind of decreasing pain, trying to decrease that stimuli. Now, I said we're going to zoom in on what's happening in the spinal cord. And like I said, there's these neurons that come back down from the brain all the way down to the spinal cord, and they're supposed to be decreasing pain signals from going to the brain to kind of um, you know, keep it from being so intense. And the way that it does this is it sends signals down to turn on an interneuron here, this purple. And what that interneuron is going to do is release substances to decrease this synapse, this, transmission of excitatory neurotransmitters from occurring. So what's happening in this area here is you have lots of GABA. Again, GABA is inhibitory, and then it's going to release your endogenous, enkephalins, endorphins, and dynorphins here in order to decrease this signaling from occurring. These opioid receptors are called mu, delta, or kappa receptors. And what do you know? They are G protein coupled receptors as well. It does one of two things, what endogenous opioids and exogenous opioids do, like fentanyl and Dilaudid. It is going to block calcium channels, or it's going to open potassium channels. Remember, like I said, when we open potassium channels, we release those positive ions, and then because we're getting rid of positive, the inside of the cell becomes more negative, so it hyperpolarizes. Calcium is one of those ion channels that is in the presynaptic neuron that's involved in the release of neurotransmitters. So when you block the calcium channels, you're going to decrease the release of neurotransmitters. So it's going to decrease that signaling from occurring. So this is just one of the areas that opioids work. This is the spinal mechanism. This is going to just decrease that pain signal from even reaching the brain. Now, there are opioid receptors in your brain as well, but what's happening in your brain is different. That's now your perception of pain. I sense that pain is occurring, and there's a lot of complex processes that are happening in your brain to determine whether you feel like it's unpleasant or not. So there's two things going on, spinal and supraspinal. We won't get into this supraspinal mechanisms, but this is just a brief overview of what's going on in the spinal cord. People say that when they run, they get this runner's high. And I'm jealous of those people because no matter how many hours I run, that's never happened to me. Like I just am not capable of getting that. But what's happening is that your body, in response to being exposed to pain for an extended period of time, will increase that release of this endogenous endorphins within the spinal cord to decrease the pain signals from traveling up. But also it's being released in the brain too, so you get that euphoria that comes along with it. Local anesthetics, another big class of medications that we give in anesthesia. And a lot of times we're giving local anesthetics for smaller procedures, smaller skin incisions. Maybe we're putting in a central line, we're doing a regional block. Uh, the number one local anesthetic that we usually give is lidocaine. We also give two other local anesthetics pretty commonly, which is bupivacaine and ropivacaine. Those local anesthetics are a little bit longer acting. We're going to give those for regional blocks. We might give those for neuroaxial anesthesia, like your spinals, your epidurals. We might inject that around the nerves in the neck in order to numb up the entire arm for like a shoulder surgery, or inject it into nerves, near nerves in your legs to numb up, an entire region of your leg. How do local anesthetics work? They block sodium channels within the neuron, and by blocking the sodium channels, they prevent the transmission of action potentials from occurring. So we talked earlier about the pain pathway, about this first part here, right? This transduction and transmission. So we're stimulating a nociceptor, and we're sending that transmission down via an action potential. But local anesthetics even just prevent that action potential from going anywhere. So we have our neuron here. What's happening at the very beginning is that you have these nociceptors here. You might have actually heard of some of these nociceptors. Have you heard of TRPV1? This is a nociceptor that's stimulated by capsaicin, which is the hot pepper element. You're actually stimulating the nociceptor, the TRPV1, TRPA1 receptors, and that's what's causing like pain. Not a narcotic, just has analgesia properties. You're talking about, Keith, you're talking about local anesthetics. So we're going to stimulate the nociceptors here. And from there, that is going to turn into an action potential. So it's going to stimulate these sodium channels here, which is going to fire that action potential and send it on its way. How local anesthetics work is they just completely block the sodium channel so that you can't even send the action potential. So no matter how many times you stimulate the nociceptors, you're stabbing it with needles, you're cutting it with a blade, whatever, it just doesn't go anywhere. And so you don't get to your spinal cord, you don't get to your brain. Local anesthetics are interesting in that they don't bind to the outside, which would seem like the most efficient route. They actually, the binding pocket's on the inside of the cell. So local anesthetics have to have this really interesting property where they switch between being lipid soluble and being water soluble. And this is where people were like, oh, pKa, I hate pKa. pKa is really involved in this switch, this ability to go between lipid soluble and water soluble. And the reason for this being is that there's no way for that local anesthetic to get into the cell except to go through the plasma membrane. There's no channel for it, there's no highway for it. It has to squeeze between those phospholipids. So, in order to do that, it has to become uncharged or lipid soluble, cross into the cell, turn back to being water soluble and then binding to the inside of the sodium channel. And by doing that, it completely blocks the sodium channel from allowing those ions into the cell and causing an action potential from occurring or preventing depolarization. Now we know that there aren't just sodium channels in the nerve cells, sodium channels in the cardiac cells as well, and other various parts of the body. And so we want to make sure that local anesthetics stay local if that's what we intend them to do, right? We don't want to inject very strong local anesthetics like bupivacaine and ropivacaine into the circulatory system, or else it stimulates other sodium channels and causes seizures and cardiac arrest. Bad. We do inject lidocaine into the cardiovascular system, and actually, we know that it is anti-dysrhythmic. But the other local anesthetics are quite toxic and have the opposite effect. So just understanding the kind of differences between those local anesthetics makes a big difference. We do add adjuncts to our local anesthetics to change its duration of action. For example, we may add epi to our local anesthetic because we want that local anesthetic to stay in its spot for as long as possible, but eventually it starts to diffuse into the bloodstream and go away and be metabolized. If we can squeeze those blood vessels that are near that site for as long as possible, it's going to decrease the amount of diffusion into the blood and going away from that site. So it just increases the duration. Sometimes the area that we're working in might be infected or really acidic. And so if the tissue is like infected and acidic, this switch from going between charged to uncharged, back to charge is less likely to occur. It doesn't occur as much. So we might add things like sodium bicarb to change the pH of the environment in order to increase the number of ions that are more lipid soluble. If that makes sense. So we might add a couple things. You might see people add different things to it. And the last area we're going to talk about is the neuromuscular junction. So pretty much every general anesthetic that you're going to give some kind of muscle relaxant, A, to facilitate intubation, and B, to facilitate the surgery. There are several muscle relaxants that we can give. That we give quite often. Succinylcholine, rocuronium, vecuronium are still the mainstays. If people have weird conditions like end-stage liver failure, end-stage renal failure, we might give other drugs like cisatracurium. But these are the main ones that we give in the operating room. And to understand these, you have to understand the neuromuscular junction. So remember I said nerve to muscle, these areas are really important to understand what's going on. So same thing with the nerve to nerve. You have an action potential that comes down. You stimulate these calcium channels, which then stimulate the vesicle that's carrying your neurotransmitter, in this case acetylcholine, to the cell memory to then release into the synapse. But now the synapse is the muscle. And the postsynaptic receptor here is not GABA. It's actually a nicotinic receptor. Excuse me. So the neurotransmitter is acetylcholine. The postsynaptic receptor is the nicotinic receptor. It's going to stimulate those receptors, which then open this ion channel, allow ions, sodium to go in, potassium to go out. It causes the action potential to then travel down the muscle cell here, these T tubules. And then calcium is released, which then does that whole troponin, tropomyosin, actin-myosin thing. And then you have your muscle contraction. So we don't want muscle contraction to occur during intubation and during the surgery. So we want to keep this process from occurring here. And we can give one of two drugs. I would say two classes of drugs. We have depolarizing muscle relaxants. We have non-depolarizing muscle relaxants. The easier one to describe is the non-depolarizing muscle relaxants first. So you're gonna give the rocuronium. It's gonna block the nicotinic receptor, and that's just gonna prevent any action potential from occurring in the muscle. So it's just gonna cause paralysis that way. So you can't stimulate those receptors from occurring. They're longer acting. They work pretty quickly, within, depending on the dose, 2 to 3 minutes, 1 to 2 minutes. And they last for anywhere from like 35 to 45 minutes, depending on the dose. Succinylcholine is different. So this is called a depolarizing muscle relaxant, and that's when you stimulate the the receptor to actually open. The exchange occurs and the action potential occurs. But what's happening here is that there's no enzyme within the neuromuscular junction itself, when that cell, to break down succinylcholine right away, like there is for acetylcholine. Because acetylcholine binds, unbinds, gets broken down by the acetylcholinesterase right away, and it's done. The thing is done. Because there's nothing to break down succinylcholine, it just kind of sits there and just keeps the channel open, and it has no way to reset. And so it just causes this flaccid paralysis. It's a different type of paralysis. So we call it depolarizing because you'll see patients shake after they get the succinylcholine, and then they stop shaking, and then they can't move at all. And the duration of action is determined by when succinylcholine diffuses out of the synapse into the bloodstream. It gets broken down by an enzyme in the bloodstream called plasmacholinesterase. So it kicks on pretty quick, within 30 to 60 seconds, and it's actually off pretty quick, relatively quickly, within 8 to 10 minutes. But the way that it does it is it holds it open and just keeps it open and doesn't let it reset. All right. That's the neuromuscular junction. I want to point out too, we give Sugammadex now to reverse rocuronium and vecuronium. And keep in mind that Sugammadex is like a donut shape, and it fits perfectly around the rocuronium and vecuronium, but only those drugs. It doesn't break down succinylcholine. It doesn't break down cisatracurium. So if you give any other medication besides rocuronium and vecuronium, you still need to, like cisatracurium, you still need to know how to use neostigmine. And I think that's a skill that a lot of people haven't developed as well nowadays, is how to time that neostigmine well. Because you can slam that Sugammadex right at the very end, and your patients, start moving right away. But that neostigmine, you have to time it. And I mean, Becky will laugh at this too, because her and I have been practicing about the same amount of time, but like that was like a sphincter tightening moment, because you still had to give it when they were like doing surgery still, because you had to give it kind of early. So it's, I definitely think we're lucky to have Sugammadex nowadays, but if you don't develop that skill with neostigmine, you can get burned in the future. So just keep that in mind. All we use is neostigmine and glyco. I'm sorry, Caitlin. Yeah, I think a lot of it is cost related, why people are still using it. All right. We're not going to go into cardiac pharmacology because we're getting late on time, but certainly I just want to go over the different classes. So lots of cardiac meds that you already know of: sympathomimetics, dilators, inotropes. We just got in trouble for using too much Sugammadex. Yeah. They used to not even put it in the OR. They used to just lock it in the Omnicell outside of the OR, so you had to like ask somebody permission to like get it for you. That was pharmacy's way of trying to control it. Cardiac pharmacology, there's a lot to know, a lot to cover. We definitely cover a lot of this in our cardiac pharmacology course. So if you want to learn more about specifically cardiac pharmacology, definitely go on our website and check out the course that we have, and it breaks down all of these, drug classes into different lessons and modules. All right, let's just finish this up with some top drawer drugs. So I didn't edit these or anything. There, you can still hear us talk in the OR. So this is the first drawer. It's kind of what it looks like. So we usually have a little space here where we put all the medications that we've drawn up for the case. And then I'll play this one more time so you can see. Oops. You can kind of see what the top drawer looks like. So you see sticks of medication here, phenylephrine, succinylcholine, and your emergency drugs here. So what you're going to see is epi, atropine, and calcium chloride. You'll see Bristol-jets of lidocaine. You'll see syringes of succinylcholine and rocuronium. You might see propofol. Sometimes they lock it up, sometimes they don't. Ephedrine and phenylephrine, which can increase your blood pressure. Neostigmine if you need it, and sodium bicarb. Those are the typical drugs that you see in your first drawer. So I just already talked about a lot of these medications, so maybe we'll focus on some medications that, and you guys are going to give me the answers. Just, I'm sure with the 150 people that are on here, we can come up with some answers here. So Becky, since you're practicing too, you can help me come up with some questions. You can unmute yourself. All right, in the operating room, why, and I have somebody that has hypotension. Why would I give somebody ephedrine as opposed to phenylephrine? What's the main factor that we're going to look at? And
And
maybe I know
maybe I
people
know people.
oh, I'm echoing. Maybe somebody can unmute and describe a little bit more by what you mean by heart rate, because I'm quizzing you. This is the top drawer quiz. Anybody want to give it a stab? Why you would give one versus the other?
Yes, phenylephrine has like a reflex.
Go ahead. I can hear you. Hello?
Neo can cause reflex bradycardia.
Mm-hmm. So if we're taking care of a patient, what are we looking for specifically? Can you describe a little bit more?
I could try.
Go for it.
Um, and does it have to do with ephedrine? It stimulates the beta two, so you're getting some kind of bronchodilation effect also.
It does theoretically stimulate beta 2. It's not the main reason that we look for as to why we would choose one or the other. Um, so a lot of people are talking about the heart rate. And if we have somebody that has hypotension, say we have a patient that has blood pressure that is 70s over 50s, 70s over 40s. The thing that we look at first is, of course, why are they having hypotension? You want to fix the why first, fluids and all that. But if you need a temporary fix until you can fix the reason why, we often look at the heart rate because people have said that phenylephrine causes a reflexive bradycardia. So if the heart rate is already low along with the blood pressure, we don't want to lower it even further by giving phenylephrine, right? We want to avoid doing that. So, but if the heart rate is high, so if they're hypotensive but they're tachycardic, then that might be a more appropriate situation. And we're like, okay, we'll give phenylephrine as a temporizing measure. We'll increase the blood pressure and we'll decrease the heart rate at the same time. But if you have hypotension and bradycardia, and you had mentioned this, you mentioned beta 2, but more beta 1, ephedrine is going to increase both. It's going to increase the heart rate and the blood pressure. So that's might be a decision-making process and why we might use one versus the other. Cool. Um, okay, since we were talking about neostigmine, what is the mechanism of action of neostigmine?
Does it reverse the non-depolarizing drugs?
It does reverse non-depolarizing drugs. Okay, so some people
With neostigmine, oh, sorry.
go ahead. Nope, go for it. I'd rather you guys answer.
I was gonna say neostigmine, it's an anticholinesterase. So when you have the neuromuscular blockade that's taking up all those acetylcholine receptors at the junction, what'll happen is this cholinesterase will break down our natural acetylcholine. So neostigmine will stop the breakdown of the acetylcholine so that it builds up enough so that it can start to saturate some of those receptors, but you have to have at least some receptors available. Like, so you have to have at least one or two twitches, I believe, before you could use neostigmine, or else if they're still all occupied by the neuromuscular blockade, it won't work.
Yeah. I hope everybody was able to get that. So I will say one little tweak I will make for that explanation because it otherwise was very perfect. So you have acetylcholinesterase, which is the enzyme, right? And like you had described, acetylcholinesterase breaks down acetylcholine. Neostigmine is acetylcholinesterase inhibitor, so it inhibits the inhibitor. So just that little tweak there. But yeah, in order to get rid of rocuronium or vecuronium for the neuromuscular junction, you have to produce more acetylcholine to outcompete that molecule for that site. So you need to build up the acetylcholine to basically fight the rocuronium off of the nicotinic receptor. And like you described, in order to do that, you have to inhibit the inhibitor, and that's what neostigmine does. Unfortunately, neostigmine also increases acetylcholine in other parts of the body too. And so one of the areas, one of the areas that we're really concerned about this happening, and what's the antidote for that?
I would say airway.
Not airway. Alex got it. The heart. So within the heart, you have muscarinic receptors. Muscarinic receptors and nicotinic receptors are structurally very different, right? Nicotinic receptors are ion channels. Muscarinic receptors are G protein coupled receptors, but they both use acetylcholine as the endogenous ligand. And what happens with the muscarinic receptors in the heart, if they're stimulated, it causes bradycardia and asystole. So if you increase acetylcholine really high in the whole body and in the heart as well, you're going to cause bradycardia and asystole. So people, a couple people like Leslie, Casey, and Lauren said the antidote for that is you have to give glycopyrrolate, which is an anti-muscarinic, with the neostigmine in order to prevent this side effect from occurring. Always push the glyco first, because I one time pushed the neostigmine first, and that's scary. So push your glyco. Some people even mix it together. I don't like mixing drugs together, but push your glyco first. All right, cool. Second drawer. A lot more. This is the scary drawer. People talk about the top drawer. It's the middle drawer. That's the scary drawer. Okay. This is where, the other medications, you're using them all the time. You read about them all the time. This drawer, though, you have medications in here that you don't use as often. So when the CRNA opens this drawer and starts pointing this stuff, this is when you start sweating, I think. This is where it kind of gets a little crazy. So let's do a couple more. It's getting to be 9:15, definitely past my bedtime, so Eastern time. So let's do a couple and see how much we get through. All right. Becky, if you have any questions, you better ask them as well. I'm just coming up. I don't even have them written down. I'm just coming up with them at the top of my head. All right. So say you have a patient now that is hypertensive, right? And so you have a lot of medications that are on here that can decrease blood pressure. Why? Which medication? Okay, so say you have a patient that is hypertensive but has a heart rate of 55. Which medications would on here would you choose and why?
Is hydralazine here? Let me check.
Yep, it's on here.
So I think you're talking about hydralazine because it causes that reflex tachycardia
Hmm.
when you give it. But with hydralazine, it takes a while. It doesn't work right away. I think it takes like 10, 15 minutes. Like it takes a little longer
Yep,
to work.
it takes at least 15 minutes to kick in. Right. Because if you're going to give your beta blocker, you're going to decrease your heart rate even further in some points. All right. Uh, let's see. What are the differences between diphenhydramine and famotidine?
Diphenhydramine is an H1 antagonist versus famotidine, I think, is H2 receptor
Correct.
antagonist.
Yep. And what clinical situations would you use them for? Anybody could answer. Why would you use diphenhydramine and why would you use famotidine? PONV, anaphylaxis.
I would use famotidine for like maybe if the patient said like there's a history of GERD and they didn't take their medication that day, I would consider giving to them versus Benadryl allergies if they're having anaphylaxis or yeah.
Yep. Right. So diphenhydramine, those histamine receptors are more centrally related. So you think about, the central nervous system, you can talk with chemoreceptor trigger zone, whereas just famotidine, those histamine receptors are more in the gastrointestinal system. So I might even give some diphenhydramine if I have like somebody that is like really frail that I just don't want to give any other sedative for. I might just give a little like touch of Benadryl and that's it, and some hand holding for that. Um, if I want to administer naloxone, how would I administer that? And it usually is supplied in, I think, zero point 0.4 mgs per ml. Correct me if I'm wrong. I haven't used it in a while.
You can draw it up with 9 mLs of normal saline, and then you can give it in doses of just 1 ml, so it'll bring it around 40 mics.
Correct. I think a lot of people, and I didn't know this either going into anesthesia school, that we used to give like the entire vial. But if we do that, what's the main adverse effect that can happen when you give an entire vial of Narcan?
You precipitate withdrawal symptoms.
Could, if they have substance use disorder, if they're
Pulmonary edema.
pulmonary edema is the main one. Yeah, so yep, sympathetic stimulation, pulmonary edema, and of course, like they're gonna wake up in excruciating pain. We give it because we want them to just start breathing, like they're apneic. So we don't want to take away their analgesia. We just want them to start breathing. So we're only going to give 40 mics at a time when we're giving the naloxone. I'm going to pause for a second. There's a lot of people that are on this call. Raise your hand if you feel like these questions are like way hard, or just tell me in the chat. Do you feel like these are hard or easy? I don't know if I should go harder or if I should go easier. They're fair. Okay, medium. Well, okay, let's just say this. If you feel like they're easy, then you're doing okay. And if somebody ever quizzes you in the OR, then I think you'll be fine. All right, you want me to go harder? All right. So, what's the difference between, those would be like my last two. What's the difference between dexamethasone, hydrocortisone, and methylprednisolone? Vincent has this like, oh shit look on his face. Chris said not that hard. All right, Alex, good, good. Nice, Brandon. So dexamethasone is a pure glucocorticoid, and the other ones have more mineral corticoid activity. That's very good. There's actually a whole chart that you can look up on the internet that tells you the various amounts of glucocorticoid versus mineralocorticoid activity. Certainly, if you want to learn about more about steroids, learn about the adrenal gland, the different layers, the different um, hormones that they produce and what they do in the body, and why we would give one drug versus the other. If you are going to stress dose somebody, which medication would you pick, and in what situations would you stress dose that person? Sepsis, ARDS, chronic use, chronic steroid use. After etomidate in a septic patient. Chris, can you explain why you said that for people that are listening?
The adrenal suppression that comes after etomidate, just to kind of ward off the body's or to help the body make their own catecholamines again.
What would happen if they had adrenal insufficiency later on? Well, what does that look like?
They wouldn't be able to make their own catecholamines, like they wouldn't be able to keep their blood pressure up.
Right.
Is my
Hypotension.
understanding.
If you have an ICU patient that's hypotensive after having surgery, 6 to 12 hours ago, and they're not responding to vasopressors, and you can't understand what's going on with them, if you look through their anesthetic chart and see that they've gotten etomidate, then your antidote for that is giving a steroid, because for the exact reasons that Chris said. So just keep that in mind. That adrenal insufficiency is a real thing. We just don't see it very often because we don't take care of ICU patients anymore, right? Dump them and we're on to the next one. Cool. We could go all night with this, right? Maybe we should have like a whole another like Instagram session on just doing top second drawer drugs. Third drawer, more of your antibiotics, your inhaled anesthetics, yeah, Afrin, albuterol. All right, you want to do it an all-nighter? I have lab tomorrow. Let's do an Instagram live where we're doing more of these questions. We can go real easy, real hard. And of course, your controlled substances as well, knowing what the differences between your opioids, your benzodiazepines, learning ketamine. I love ketamine. You either like love it or you hate it. Some people hate it. I'm a lover of ketamine. I think there's a lot of important situations in which it comes in handy. I also did a lot of trauma. Um, I did probably trauma anesthesia for about 8 years straight of trauma call. And I mean, we used a lot of ketamine. So it's a great drug. Yeah, Elizabeth, I love ketamine. Keeps them breathing, keeps them hemodynamically stable. So it's a cool drug. So I'll just keep a open discussion. Are there any drug classes that you want to learn in more detail that I should focus on in future sessions? Of course, this was like a general overview, just an introduction to the field. Well, we can do a deep dive into anything that you think of. Dilution and fast math. Actually, I just went to ADCE, which is Becky was there with me. She's my roommate. We went to it's the Assembly of Didactic and Clinical Educators Conference. We went to that in Tucson, Arizona about a month ago, and they had a whole session on anesthesia math, which I took lots of pictures and it's becoming like a big thing now, is really teaching math skills really well. Local anesthetics and max doses for different local anesthetics. Should we do PK in there as well? Dilutions in math. Cool. All right. See, I like to see all the interest in math. A set of scenarios with the best drug choice and rationale. Okay. Nice. Now we have class with Becky. That's funny. Nice. Okay. Awesome. Well, I always say at the end, what's the next webinar is and what's going on. So we are continuing to build our YouTube channel. We have 3 videos out there now. YouTube is hard. I could like crank out podcasts all day long, but man, like YouTube is like a lot of work. So as I finish up my PhD in the next month, we are going full force into building the channel for you guys, creating the learning platform, continuing to crank out the content. If you haven't heard, Sashi and I have been invited to host the College Bowl this year at the ANA Annual Congress in Nashville, Tennessee. So definitely, yeah, I'm super excited about that. We're super pumped. We're going with the mad scientist theme for this one, like hot pink lab coats, Einstein crazy hair. Our next webinar is about cardiac anesthesiology. Usually, keep this in mind, usually it's the last Wednesday of every month. I have a really cool guest speaker who's on a lot of my podcast episodes, Alex Gorman. He's a full-time practicing cardiac nurse anesthesiologist up in New Hampshire. He is going to join and lead that session, but he's on vacation that week. So we're going to push this to May 7th. So put that in your calendars. He has some really cool TEE images. He takes you through step by step, like how to set up, how to get through, bypass surgery, valve surgeries. Lots of cool pictures, lots of like clinical insight. So you definitely don't want to miss that one. So May 7th. And yeah, just email me if you have any suggestions. I'll have the chat saved with all your suggestions. And I'm looking forward to seeing you guys next time. Thanks for coming. Good night, everyone. I'll post this and send it to you in a day or two.